What's up everybody, Dr. Rossi, shrinksandSneakers.com. In this video, what I'm going to do is answer a question that was requested by some of our viewers, and that is to talk a little bit about schizoaffective disorder. So this question comes up a lot. Is it bipolar disorder? Is it depression? Is it schizophrenia? Is it some combination or spectrum of all three? That's what we're going to attempt to answer in this video. The first thing I'll say is that making the correct diagnosis is critical. So it's critical for our patients because it can determine treatment course, it can determine in some cases prognosis and outcomes. So we want to make the correct diagnosis, and diagnosis is king. And sometimes as we start to see patients over a period of time, diagnoses can evolve, and sometimes patients get frustrated with the idea that they may initially be diagnosed as bipolar disorder and then end up with a diagnosis of schizoaffective disorder later on, or schizoaffective bipolar type later on. And I'm going to explain more about this in a few minutes. So, to start with, schizoaffective disorder, what is it? It is a combination of schizophrenia and mood symptoms. So, schizophrenia being your common cognitive deficits, as well as the classic positive symptoms, things like delusions and hallucinations, and then the mood disorders being either bipolar disorder and or depression. So you might be thinking, well, it's pretty easy and intuitive when you're looking at this this term schizoaffective disorder to kind of determine what this is. So the affect is your emotions or your feelings, and schizophrenia, or the schizo part, is the cognitive disorder affecting your thinking. So there's going to be not only a mood component here, but also something affecting the cognitive component as well and affecting your thinking. So there's a lot of debate about whether or not this should be classified as a separate disorder, or should this be classified as some type of combination or in the spectrum of schizophrenia or bipolar disorder. So this is an interesting debate in psychiatry in general. There's a lot of question about the bipolar spectrum, so meaning that there's many different subtypes of bipolar within this bipolar diagnosis. And one of the things DSM-5 did that was good and bad is that they simplified the diagnosis to kind of catch all. But what it did was it eliminated some of these nuance points that I think are actually clinically relevant. So we're missing some of those nuance points now. So is it a spectrum? Is it in the spectrum of schizophrenia, or is it in the spectrum of bipolar disorder? So one potential way of thinking about schizoaffective disorders, it's kind of like having schizophrenia with a superimposed mood disorder, either bipolar disorder or depressive disorder. And so the person would get a diagnosis of either schizoaffective disorder bipolar type or schizoaffective disorder depressed type. Now, this differs from schizophrenia because a patient with schizophrenia may not necessarily be depressed, and will certainly not be meeting criteria necessarily for manic episodes. They may have agitation, but it's not the same as mania. Now with bipolar disorder, you often see patients having episodes of depression and mania kind of alternating, or in some cases you can see pure mania, but you will not see the psychotic symptoms remaining after the mood symptoms have resolved. So when the mood symptoms resolve, generally the psychotic symptoms would resolve with it. So with schizoaffective disorder, the psychotic symptoms will remain after the mood disorder has resolved, or before the mood disorder, or before the mood symptoms even began. So to phrase that differently, with schizoaffective disorder, what you will see is residual psychotic symptoms after a mood episode resolves or before a mood episode begins. And that, in fact, is one of the key criteria for making the diagnosis of schizoaffective disorder, in comparison to things like major depressive disorder with psychotic features or bipolar disorder with psychotic features. You need a 2-week period where the patient has psychotic symptoms in the absence of any mood symptoms. So there's a key diagnostic criteria separating schizoaffective disorder from things like bipolar disorder with psychotic features or major depressive disorder with psychotic features. So as I said, you can have schizophrenia with major depressive episodes. The difference primarily will be the amount of time spent in the depressive state and the amount of time spent with psychotic symptoms. So for the patient with schizophrenia who has a major depressive episode, there's only a minimal amount of time spent depressed. Majority of the time is spent with psychotic and cognitive symptoms associated with schizophrenia. Now, with schizoaffective disorder, what you will see that will be different is the mood symptoms will be present throughout, along with the psychotic symptoms, throughout most of the illness. So mood symptoms and psychotic symptoms are present throughout most of the illness together. And then there's small periods where the psychotic symptoms will be independent of mood symptoms, either before a mood episode begins or after a mood episode ends. So that's the primary difference, and we'll talk a little bit in the next section about why it doesn't really make that much difference in terms of the treatment, why there's really minimum differences in terms of how these disorders are treated. So I want to discuss treatment a little bit for you guys, because I think with schizoaffective disorder, as with bipolar disorder, depression, any psychiatric disorder, it ultimately comes down to treatment and trying to determine what is the most appropriate treatment for an individual patient. So the theory with schizoaffective disorder is that you're going to look at what the predominant symptoms are. So let's say, for example, the predominant symptoms are mania, then you're going to be looking for a mood stabilizing medication. And the traditional mood stabilizers, just like you would use in bipolar disorder, would be available options for treatment. Things like lithium or valproic acid. Now, if the person's symptoms are primarily depressive type, and there's a lot of depressive symptoms, then you're going to use a lot of your traditional antidepressants, the serotonin reuptake inhibitors, or serotonin norepinephrine reuptake inhibitors, things like sertraline, escitalopram, citalopram, fluoxetine, etc. Any of these options could be used, and depending on what the patient's presenting with. But if there's depressive symptoms, you're going to use some type of antidepressant medication. Now, the same can kind of be said here for the psychotic symptoms. The psychotic symptoms are going to need to be treated with dopamine blocking medications, and those would be your traditional medications that we've talked about or discussed in other videos, things like olanzapine, quetiapine, risperidone, ziprasidone, etc. So when you're treating schizoaffective disorder, you're likely going to be combining one of these dopamine blocking medications to treat the psychotic symptoms, and then you're going to be combining that with either an antidepressant medication to treat the depressive symptoms or a mood stabilizing medication to treat the mania or bipolar component of schizoaffective bipolar type. So you can kind of see like that treatment regimen honestly doesn't change all that much if I was treating somebody with major depressive disorder with psychotic features, or if I was treating bipolar disorder with psychotic features. I would probably use some combination of these types of medications, either an antidepressant and a dopamine blocker, or a mood stabilizer and a dopamine blocker. So it's very, very similar in terms of how this disorder is treated. And the differences in the treatment will likely come in the length of time that you're going to continue the medication for. So how long will somebody be on a dopamine blocking medication will differ between those with bipolar, those with, say, major depressive disorder with psychotic features, and those with schizoaffective disorder. But ultimately, it all comes down to a similar treatment. So I just want to say a couple quick words about the prognosis for schizophrenia versus schizoaffective disorder versus bipolar disorder and major depressive disorder. What we tend to see is that schizoaffective disorder falls in the middle there. It has a better prognosis than schizophrenia, but it has a worse prognosis than the primary mood disorders. Another thing that's interesting, or at least said in the textbooks, but I don't necessarily observe this clinically, is that schizoaffective disorder has a non-deteriorating course, meaning that patients don't have as many deficits and problems, specifically the things like cognitive deficits that's seen in schizophrenia, over time. But I still think that this is not 100% true clinically. I do think there is a little bit of a deteriorating course there for people with schizoaffective disorder, but the textbooks and data kind of tell us that yes, there is a non-deteriorating course. The other important thing to note is that schizoaffective disorder responds to mood stabilizing medications. Specifically, they point out lithium, that patients have better response to lithium than patients with schizophrenia. Now that might just lend itself to the fact that, again, there's this bipolar subtype, and this bipolar type, of course, would likely respond to a mood stabilizing medication better than someone with schizophrenia who doesn't have symptoms of mania to be treated with mood stabilizing medication. So with that said, hopefully this video is helpful for you guys. Hopefully this covers a great deal of schizoaffective disorder, makes a few of the unclear parts more clear for you. And if you have questions or comments, drop them below. And please like and subscribe to the channel so we can continue to make psychiatry videos.